time, I'd like to introduce you to our speaker. Dr. Lisa Gall is a clinical program manager at Stratus Health, family nurse practitioner, health IT leader, and certified PQRS specialist with over 30 years experience in nursing, administrative, provider, and health IT roles. After 18 years in nursing, Lisa graduated from Concordia University's Family Nurse Practitioner program. She practiced for 14 years in rural primary care, nursing home, urgent care, and emergency settings. She returned to the University of Minnesota to complete her Doctor of Nursing practice in 2010 and Health IT Leadership Certificate in 2011. She currently helps healthcare organizations and clinicians understand emerging healthcare policies such as CMS Meaningful Use, PQRS, and quality payment programs. Lisa brings a clinician's perspective to help organizations understand how value-based care affects practice, how to operationalize policies in meaningful ways, and how to enhance practice using data and technology. Lisa is lead clinician for Lake Superior QIN in the CMS-funded Transforming Clinical Practice Initiative and sits on the CMS Technical Expert Panel for the Quality Measures Development Plan. She has published, taught, and presented on various health IT topics, and we are very lucky to have her present for us today. Lisa, I'll turn it over to you.
Thank you, Kim. I'm so honored and excited to present this webinar series about MACRA's Quality Payment Program. First, I'd love to talk about healthcare quality and practice transformation using technology. And second, I'm thrilled at being able to present to a group near and dear to my heart, which is small, rural, underserved healthcare settings. As Kim said, I grew up, practiced as a nurse and nurse practitioner and still live in rural Minnesota, where it is currently about 8 below zero. For those of you in warmer weathers, I feel a little jealous of you. A special thanks to National Rural Health Resource Center for arranging the webinars for participants of the Small Rural Hospital Transition Project, and to Stratus Health for allowing me to present today. Oh, I do have to advance these slides. So we have a lot to cover today, and so I want to just let you know that I'm going to talk rather fast at times. If you don't understand me, there's an opportunity for questions at the end. We will be covering the Quality Payment Program and Value-Based Care, the 2 Quality Payment Program tracks, which are merit-based incentive payment system and alternative payment models. We'll talk about eligibility and the effects on payments for hospitals and clinics, how to work with clinicians affected by the Quality Payment Program, and lastly, review the Quality Payment Program timeline and the 2017 transition year, also known as Pick Your Pace options. The Quality Payment Program was born out of bipartisan MACRA legislation, which was passed in, oops, I'm sorry, I'm one slide ahead of you. I got to talk about Stratus Health. I currently work at, as a clinical program manager at Stratus Health. Stratus is a quality improvement organization and the lead organization in the Lake Superior Quality Innovation Network. We address and serve in program areas such as health IT and rural health, which fits this webinar very well. So diving into the Quality Payment Program and Value-Based Care, the Quality Payment Program was born out of the MACRA bipartisan legislation passed in 2015. Which repealed the sustainable growth rate, the flawed sustainable growth rate formula, and also in 2016, the new payment model was named the Quality Payment Program and streamlines multiple programs into the new MIPS, which is the Merit-Based Incentive Payment System, and incentivizes participation in advanced alternative payment model. So the 2 tracks or pathways through the Quality Payment Program are MIPS and APMs, And I will be referring to those as acronyms, and if anyone needs a list of acronyms, there is a list on slide 61 of acronyms. If you're not sure what I'm talking about, you can refer to slide 61. So this slide depicts how the CMS is shifting Medicare Part B payments from volume to value by rewarding. I'm going to go one further ahead because I put these out of order. This slide depicts how CMS is shifting the payments from volume to value by rewarding clinicians for positive outcomes for both individual patients and populations they manage. The center area shows that value is really the combination of cost, quality, and patient experience. This is important in realizing the true meaning behind the quality payment program, which is better care, healthier and engaged patients, and lower cost. And now I'm going to backtrack onto the slide I started before. The three current programs are integrated into CMS's merit-based incentive payment system. The Physician Quality Reporting Program, Value-Based Payment Modifier, and Medicare EHR Incentive Program, also known as Meaningful Use. They're combined into a new way of reporting in areas of those three programs under MIPS. The quality payment program moves away from all or nothing reporting requirements that were previously mandated under Meaningful Use NPQRS, allowing clinicians to choose the metrics that make the most sense. I think in this part, CMS has really listened and has done a good job of listening to what was not working with those programs, and also keeping in mind, the end goal of improving care, decreasing costs, and having healthier and happier patients. They also want to reward clinicians for value and positive outcomes, using Medicare Part B payment adjustments in either negative payment adjustments, neutral, or positive. And the MIPS legislation allows for $500 million divided among high performance for the first few years as a bonus payment if you're in the high performance category. Eligible clinicians will be scored under 4 MIPS categories. Now, I mentioned 3 programs. They are adding another category that I'll go through in a little while. So you'll be scored under 4 categories, but the transition year in this year has lower scoring thresholds under only 3 of the MIPS categories. Excuse me. The scoring for the merit-based incentive payment system is based on the 4 performance categories of quality, cost, improvement activities, and advancing care information. As you can see, the cost one is grayed out this year. That is the old value-based modifier payment program, which looked at cost based on claims. So now clinicians will choose activities in these areas and measures that are more meaningful to their practice, and the reporting standards also align with advanced alternative payment models where possible. So we'll talk a little about eligibility and how payments are affected in the next few slides. There are 5 types of clinicians who may be MIPS eligible, which means they're subject to payment adjustments. And those payment adjustments, when I say payment adjustments, they could be positive, negative, or neutral payment adjustments. So physicians, nurse practitioners, physician assistants, clinical nurse specialists, and certified registered nurse anesthetists are all affected by MIPS in 2017 and eligible for MIPS. Clinicians who are excluded from MIPS are those who are newly enrolled in Medicare for the first time during the performance period. They're exempt until the following performance year. so a new graduate or someone who's billing under Medicare Part B for the first time. Anyone who's below the low volume threshold, and that low volume threshold really impacts those in small and rural settings. And they look at the Medicare Part B allowable charges. If you bill less than $30,000 per year, or C, 100 or less Medicare Part B beneficiaries every year, you are excluded from MIPS payment adjustments. The third area of exclusion is if you are significantly participating in advanced alternative payment model. And in order to be significantly participating, you need to be receiving 25% of your Medicare payments or see 20% of your Medicare patients through an advanced alternative payment model. This legislation also includes non-patient-facing clinicians who can participate in MIPS. And if they don't have exclusions that were mentioned in the previous slide, you are considered non-patient-facing if you have 100 or less patient-facing encounters during your performance period. The benefits of that is that there are more flexible reporting requirements for non-patient-facing clinicians. And some of those non-patient-facing clinicians could be like pathology, anesthesiology, radiology, nuclear medicine, and interventional radiology providers. Those are some examples under the MACRA legislation. The top left of this slide shows that hospitals under Medicaid and Medicare EHR incentive program, this is how it was in 2016. The top left is Medicaid and then Medicare eligible hospitals and critical access hospitals. On the right is meaningful use for Medicaid eligible professionals, and on the right upper lower area it shows the meaningful use for Medicare. Of those providers, eligible professionals, only the meaningful use for Medicare EPs are included in the MIPS quality payment program. And they can choose between either advanced alternative payment models or MIPS. And if you are not meeting the criteria for seeing those 20% or 25% of payments and costs, you will be included under a MIPS APM, and I'll explain that a little further down the road. So CMS expects about 5 to 8% of eligible clinicians to report under advanced APMs in 2017. So it's a small percentage nationwide. And the remaining 92 to 95% should fall under either MIPS or MIPS APMs. So MIPS has the 4 reporting categories. And the MIPS APMs, there's special scoring. Some categories may apply and some may not apply depending on your alternative payment model that you're associated with. In the top of this diagram are Medicaid meaningful use EPs. What is previously known, EP is an eligible professional. The Medicaid eligible professionals should continue to report under your state EHR incentive programs. So it does not end meaningful use for Medicaid eligible professionals. That continues through 2021. 2016 is the last year to begin the Medicaid meaningful use program, either adopt, implement, or upgrade, or meaningful use. And there are pretty significant incentive payments, as you can see, for up to 6 years under Medicaid incentive programs. The Medicaid eligible EPs are not excluded from MIPS if they bill Medicare Part B physician fee services. They need to continue to report to both programs as they are now separate. The last bullet is significant for small and rural hospitals. While the Meaningful Use program excluded hospital-based providers for the EHR incentive program, the Quality Payment Program is based solely on Medicare Part B payments, which includes hospital-based outpatient services, not excluding facility charges. So if your hospital bills for ER services under Part B of Medicare, Method 2, if you're a critical access hospital, those clinicians who work in those areas are MIPS eligible. Just a quick question here. I just want to do a quick survey. Do you have any 2017 MIPS eligible clinicians who are eligible in 2017? And you should enter everyone that applies. Not, because you could have more than one answer if you have multiple clinicians.
And while we wait for those results, Lisa, I just want to remind everyone that, I just want to let everyone know that the updated slides for today's webinar can be accessed in the left-hand column where it says download slides. If you click on that and then upload it to your computer, the slides that were attached in the meeting invite for today are not the most recent updated slides today.
And I will add, if you did use those slides or if you are looking at them, there are a couple of errors in there, and so we did correct them and upgrade them. How are we doing, Kim? Do you think that's it?
Are you able to see those results for
yes.
the broadcast?
So,
okay.
Yes, I can see them. There are 10% or 2 people who said no, they do not have any MIPS clinicians. 14 said that yes, they previously reported to Meaningful Use, which is 66%, and 9% yes, never reported to Meaningful Use. 52% said yes, previously reported to PQRS, and 9.5% yes, never reported to PQRS. So, a lot of them have previously reported to Meaningful Use, but not to PQRS, which is not surprising in the settings that you work in. Okay. So I'm going to talk about the 2 paths or tracks, they're called both, to the Quality Payment Program. So there are 2 tracks, either under the Merit-Based Incentive Payment System, where you get performance adjustments and possibly a high performance bonus, or advanced alternative payment models where you have your benefits through your APM for high quality and high value outcomes and possibly a 5% bonus from Medicare. So the majority of eligible clinicians, and I'll use the word, CMS has coined the word eligible clinicians in 2017 for the Quality Payment Program. In the past, they were eligible professionals, and that is referring to the Meaningful Use program. So if you have an eligible professional, it's for Meaningful Use. Eligible clinicians are for the Quality Payment Program. So the majority of ECs will be taking the MIPS path in 2017. As you can see, there are MIPS applies weighted scores for 4 performance categories based on a 100-point scale. The categories can be reweighted in certain circumstances, but generally quality accounts for 60% of the 100 points. Improvement activities account for 15%, and advancing care information accounts for 25%. And advancing care information is the old Meaningful Use, quality is old PQRS, Improvement activities is a new category this year that you can choose, several activities and quite easily probably complete all of the scores for that area. The second path is alternative payment models. And an alternative payment model is a payment approach that gives added incentive payments to provide high quality, cost-efficient care. Under an alternative payment model, the payments to the clinicians or organization can apply to a specific clinical condition, a care episode, or a population. And it may offer opportunities for eligible clinicians who are not ready to participate in advanced alternative payment models. So advanced alternative payment models are a subset of the APMs. And the subset of APMs is known as advanced alternative payment models, receive greater rewards for taking on risk related to patient outcomes. So besides the rewards in the advanced APM that you're a part of, you do receive a 5% lump sum on incentive payments. And this may not apply to many of you who are working small rural hospitals, but if you have eligible clinicians and you are considering being part of an APM, this is significant if you're billing to Medicare Part B. And it's also important, I'm just going to back up, it's also important on this to understand that even though you don't have clinicians who are eligible, that you will be, your hospital or your rural clinics will be working with others who are working under APMs and really needing to understand that they're looking at the overall health of their patients and populations in a different way than we've looked at them in the past, and looking at population health and team-based care, and they're going to be asking your organizations to work with them to get their patients to a better outcomes and healthier lifestyle. And really avoiding a negative payment, if you do have qualifying eligible clinicians, avoiding a negative payment adjustment is, in 2017 is very easy. I'm sorry, easy is kind of covered on this slide, but really in order to get a negative payment adjustment, you don't report anything. But in order to get a no payment adjustment, all you need to report is either one quality measure, one improvement activity, or the required elements in the advancing care information measures. And that's the minimum amount of data to avoid negative payment or downward adjustments. The reporting options under MIPS are either you can report as an individual, and an individual is an NPI number plus TIN combination where you reassign benefits. And as a group, a group is considered 2 or more clinicians with NPIs who have reassigned their billing rights to a single tax ID number, or as an advanced alternative payment model entity. So I'll talk a little bit about the MIPS Quality category. The quality category, previously known as PQRS. Most individuals can report up to 6 quality measures. Groups using CMS web interface can report 15 quality measures for the full year and must register by June 30th. In order to use the CMS web interface, you need to have more than 25 in a group, very similar to PQRS in the previous years. MIPS eligible alternative payment model clinicians report quality measures through their alternative payment model, not directly to CMS. And those are like Shared Savings Track 1 or the oncology care models. I'm going to back up. I forgot to mention a point here. If you do not, if your clinicians, or eligible clinicians, have not reported to meaningful use in the past or do not qualify for the advancing care information category, that score, that 25% of the MIPS score may be reweighted to quality. So the quality measure may go up to 85% of the weight of the total MIPS score. How do you report to quality measures? 4 ways for individuals, either through a qualified registry, an EHR, a qualified clinical data registry, or claims. Groups can report either through qualified registries, EHRs, qualified clinical data registries, and as I mentioned, the CMS web interface for groups of 25 or more, or the CAPS for MIPS survey. The next category is improvement activities. This is the new category under the quality payment program, accounting for 15% of your MIPS score. It's designed to help participants prepare to transition to alternative payment models. And there are 9 categories that are expanded access, population management, care coordination, beneficiary engagement, patient safety and practice assessments, participating in an APM, health equity, behavioral health integration, emergency preparedness and response. There's a lot of categories, and you know, and even things that you wouldn't think that you normally do in your day-to-day operations could be included in these improvement activities, and you could probably easily find some things that you could easily do to reach that 15%, 100% of the 15 MIPS score. The activities are weighted. The medium activities are 10 points and high activities are 20 points. There are special considerations for small, rural, and underserved clinicians. They actually receive double points for improvement activities, as do non-patient-facing clinicians, and those in medical home or alternative payment models have special scoring. For a full score under improvement activity, which is 40 points, you must attest that you completed up to 4 improvement activities for at least 90 days. For small and rural settings of less than 15 participants, or those in a health professional shortage area, you only need to complete up to 2 activities because you receive double points. Those in a primary care medical home, APM designated as a medical home model receive full credit, and those who are MIPS alternative payment model qualified receive full credit under this category. And then other APMs may receive half credit and can use other improvement activities to increase your score. So to report improvement activities, you must perform the selected activities for 90 consecutive days. You must attest each activity performed for a 90-day period by selecting yes, so it's an attestation. And what we have not heard clearly is what do you do to prove that you've done this, and you need to, much like the meaningful use program of the past, you need to, anything that you're attesting yes to, you should probably show that how you're meeting that activity in case of an audit. We haven't had clear audit instructions from CMS at this point, however. And you can report your improvement activities either through a qualified registry, your EHR, a clinical data registry, or the CMS web interface. The other thing with improvement activities is that you can receive a 10% bonus here besides your base score under advancing care information, which is the old meaningful use, if you complete 1 or more of the improvement activities using certified EHR technology. There are 18 of those activities available that you can use your certified EHR technology for. That list of the improvement activities, the quality measures are all on the CMS QPP website. Very easy to get to. So now we're going to talk about advancing care information category, which accounts for 25% of your total MIPS score. It replaces the Medicare Meaningful Use EHR incentive program, but not the Medicaid program. Advancing care information promotes the use of certified EHR technology, also known as CERT, especially the electronic exchange of information and patient engagement. It provides less stringent all or none reporting with flexible reporting in choosing measures and multiple ways to score well in this category. In 2017, there are 2 measures sets for reporting depending on the version of the certified EHR that you use. So what CMS has done is they've taken the Advancing Care Information Objectives and Measures, which use a 2015 certified EHR technology and stage 3 meaningful use, or you can use the 2017 Advancing Care Information Transition Objectives and Measures, which is where most people will likely report this category because they're using 2014 certified EHR technology and the current modified stage 2 meaningful use objectives. So eligible clinicians must attest to 4 or 5 base measures in the Advancing Care Information category in order to receive any score. And the 4 or 5 depends on the certified version, EHR version that you're using. And those are 4 or 5 areas. Everyone must complete a security risk analysis to score anything in this area. They must do these 4 or 5 things to score anything in this area. E-prescribing, provide patient access, and send a summary of care. If you're using the 2015 certified EHR and stage 3 meaningful use, then the 5th measure is requesting and accepting a summary of care document into your electronic health record. So besides the base score are these 5 areas, 4 or 5 areas, account for 50% of the Advancing Care Objective score. You have a performance score. And with that performance score, you choose to submit up to 9 measures for a minimum of 90 days for additional credit. However, you may not need to submit advancing care information if none of these measures apply to you, or if you were not required to meet meaningful use under Medicare in previous years. So this is the base measures. There's 2 slides here. The base measures are 2015 CERT on the left and 2014 CERT on the right. Some of the objectives and measures are recategorized. For example, the secure messaging and view, download, and transmit, also known as VDT, moves over to coordination of care in the 2015 CERT area. And patient education moves to e-access. So there's some shuffling of some of the measures and objectives. And then another one is that health information exchange splits to send summary of care and request and accept a summary of care document. And the medication reconciliation changes to clinical information reconciliation under health information exchange, which is a little more comprehensive, where the clinician needs to do a reconciliation under stage 3 and using 2015 CERT. All of this will be in 2018, should say mandated in 2018, at least at this point. That's the date for using the 2015 CERT. So it behooves you to start planning for 2017 to start asking your vendor when your 2015 CERT will be ready, and if it will be ready by 2018. The ACI performance measure category, the base measures that I just talked about were can account for 50%, and the performance category, a lot of these are the same measures, and you also then score with a numerator and denominator, and they're very similar to how meaningful use looks at this time with providing access, view, download, transmit, education, messaging, health information exchange, medication reconciliation, and immunization registry reporting. So these areas then you score on each of the, there's 7 on the right side with the 2017 objectives and measures, and there are 9 areas on the left side with ACI objectives and measures using a 2015 cert. These will be reweighted, and so that those using 2014 cert have just as great of a chance of scoring high in this area as those using new certified EHR technology. Those of you who are meaningful users, and it looks like a lot were, will do very well in this category because only the 5 base ones are the ones that you need to do, and the performance ones you can score where, you know, put your numbers down where you score well, and you should be able to score fairly well in this category. Excuse me for 1 minute. Oh, I was talking to myself. Sorry about that. Exemptions from advancing care information category scoring, and are that the exemptions are now for the whole category, not just for, as was in the case for meaningful use, if you had individual objectives or measures that you couldn't meet, you could claim an exclusion in some of those measures. That's not the case here. What the case is that you just report on those measures that you're doing very well, or you actually report on all of them and you do get a score, even if you're scoring low in the areas, and they all compile to give you a score. However, if you are exempt from the whole ACI reporting, you will need to either submit a hardship exemption, which was similar to the hardship exemption under the Meaningful Use EHR Incentive Program. And that, I believe, has a, I don't think they've given the date of that, but I believe in the past it's been June 30th of each year to apply for hardship exclusions. Hospital-based clinicians. Now I'm going to back up here. If you're not currently required to report under Medicare Meaningful Use, you may choose to submit or to not submit to advancing care information. This includes hospital-based clinicians. Probably most significantly affected by that is nurse practitioners, physician assistants, clinical nurse specialists, and certified registered nurse anesthetists who were only eligible under Medicaid Meaningful Use. So the big question is do you bill for these services under Medicare Part B physician fee services, including Method 2 billing? And do you meet the hardship exceptions or MIPS exclusions? And you can consider voluntary reporting to MIPS even if someone is ineligible, and CMS is encouraging small and rural clinics to do so that they can stay up to date with the processes and learn the process. The fourth category is the MIPS, under MIPS is the cost category. And this category, as I explained earlier, is canceled for 2017. However, in 2018, they will start counting this based on your claims submitted under Medicare Part B. There is no data submission required. Some of the details of the cost category It's been set to 0% for 2017. There are 10 episode measures being finalized. We don't know them yet. And performance feedback will be available on an annual basis. The category score will increase from 0 to 30% by 2021. So they're really putting a lot of meat in the cost calculation as time goes on. And you don't select those cost measures. They're based on services delivered. And they're also based on a TIN plus NPI combination. Previously, it was only the TIN in value-based modifier method. So we're going to go to the second track or path for the quality payment program, advanced alternative payment models and MIPS. So advanced alternative payment models are considered to be taking a step up from MIPS. It's a new way to compensate providers for care and services rendered to Medicare beneficiaries, such as lump sum payments and higher annual payments for some providers beginning in 2024. And providers in advanced APMs are exempt from MIPS payment adjustments and qualify for a 5% Medicare Part B payment. APMs, as a general, promote value and quality over volume by moving away from the traditional fee-for-service payment structure. This does not mean that fee-for-service is going away, especially APMs cannot be implemented, but rather it places quality at the forefront. The overall goal of APMs is to reduce spending and improving patient care. The CMS Innovation Center has developed new payment and delivery models. Congress has defined several demonstration models implemented by CMS under MACRA and the Affordable Care Act that are listed above. Some of these include this Medicare Shared Savings Program, demonstration under the Healthcare Quality Demonstration Program, and the CMS Innovation Center model. These are all listed in the qpp.cms.gov website. And this is the slide that explains that clinicians must either receive enough Medicare Part B payments or see enough Medicare Part B patients through an advanced APM to qualify for the incentive payments under the advanced APM model. So CMS publishes lists of APMs that will qualify as advanced APMs at the end of 2016. So as you can see on here, and I explained earlier that it's either the percentage of payments of 25% of your Medicare Part B payments. It's not your total patients, but 25% of your payments are billed through I'm going to say that back over again. 25% of your Medicare Part B payments are billed to an advanced alternative payment model, or 20% of your patients that you see are billed through the advanced APM. That moves up every year. Starting in 2019, it moves to 50%, and then in 2021, 75% on the payments, and then for patient calculations, it moves up to 50% by 2021. So this slide shows that, again, how under the quality payment program, you can have a MIPS eligible clinician on the right side, and an advanced APM qualified participant on the left side. So qualified participants under advanced APMs have more of a downside risk, but they can receive that in that 5% bonus payment. If you have someone who is in an advanced APM but they didn't see enough of the threshold to be a qualified participant, then that clinician is an eligible clinician under MIPS APM, and they have a different scoring and probably an easier path to higher scoring than under MIPS. So advanced APMs in 2017 are listed below. Initially, they were the ones listed in the top here, including the Medicare Shared Savings Programs Track 2 and 3, the CPC Plus, and next generation ACO models. Recently, CMS added several more on the bottom. These are all listed on the CMS website. And looking at advanced APM starting in 2018, there is looking at ACO Track 1 and a new voluntary bundled payment model and a cardiac and joint care models. And in this model shows the participation in, if you are not in an APM on the left, you have a MIPS adjustment, and based on the MIPS category score. If you are in an APM, but did not meet the criteria or threshold for being a qualified participant, then you get MIPS adjustments plus APM-specific rewards. If you're an advanced APM, you get your APM-specific rewards plus the 5% lump sum bonus. And how to earn a 5% APM incentive payment. You meet the threshold of 25% of the Medicare Part B physician fee schedule. That's the MPB and PFS payments received through an advanced APM, or 20% of patients seen through an advanced APM. And then the second thing you do is submit quality data required by your advanced APM in the performance year. And again, I'm kind of repeating again, if you don't meet those thresholds, then you're subject to MIPS adjustments. Okay, the last section of slides is about the timeline for the MIPS and quality payment program. Your performance year right now in 2017 is your performance year, and that's where you have your, pick your pace submission. You submit your data by March 31st of 2018. You'll get a feedback report from Medicare in 2018, and you'll have your payment adjustment for 2017 will occur in 2019. Like the other CMS incentive programs, it's a 2-year lag from the performance period to the payment adjustment. So the timeline for the MIPS payment adjustments, starting in 2019, where that payment adjustment comes into play from this year's performance, is a upward or downward of 4%. That goes up by 1% to 5% in the following year, 7% the year after, up to 9% in the following year. And the MIPS and quality payment program is through 2022. So this is the pick your pace under MIPS and APMs. So if you're and you participate in an advanced alternative payment model in 2017, you report under your APM. If you are under a test, which is the test pace, the first little bullet here, you submit. Even submitting a small amount of data in 2017 can help you avoid a negative payment adjustment. And if you submit partial for 90 or more days after January 1st through October 2nd, then you are a partial provider, your reporter pace, and you'll have a small positive payment adjustment depending on what your scores are in the categories. So you can actually be a 90-day partial year reporter and score well, but it will be easier to score even higher if you're reporting on a full year, especially with some of those quality measures. So if you do a full year participating starting January 1st, you do well in your quality measures, your ACI, and your categories, improvement activities, you will have a higher score and then receive a higher payment adjustment of up to 4%. The biggest take home from here is not participating and not reporting will result in a negative 4% payment adjustment to Medicare Part B physician fee schedule payments in 2019. So under the pick your pace, you can begin a 90-day reporting period or greater anytime between January 1st and October 2nd is the latest date that you could start your 90-day reporting period. And then the dates for determining qualified professionals, as we were talking through the advanced alternative payment models, if you belong to a part of an advanced alternative payment model, and your organization may have some clinicians who are eligible QPs and some who are not eligible QPs. So as an organization, each clinician has the opportunity to jump into the APM on March 31st, June 30th, and August 31st is the last date that a participant can join the APM to be a qualified professional in their APM. So this scale shows how MIPS score affects your payment adjustments. If you do nothing, you get 0 points as for a MIPS score, and you'll receive a 4% payment adjustment on Medicare Part B payments. If you report and you only have 1 or 2 points, you might receive a negative payment adjustment, but it may be not quite 4%. If you score only 3 points, then you have a neutral payment adjustment. And if you score between 4 to 69 points, there's a range of payment adjustments that will occur. If you're scoring, obviously, if you're scoring 4 or 5 points, you're going to have a lower payment positive adjustment than if you were scoring 69 points. And if you're a high performer and you scored over 70 points of the 100 possible under MIPS, you're eligible for a positive payment adjustment and the exceptional performance bonus, which has put in $500 million for those who are exceptional performers. So, last slide, looking at the impact on providers working in rural health clinics, FQHCs, and critical access hospitals. So you are subject to MIPS payment adjustments if your provider is an eligible clinician and sees more than 100 Medicare patients or bills more than $30,000 to Medicare Part B in the performance year, including the method 2 critical access hospital billing for professional services. How this works is that CMS makes those determinations of eligibility regarding the low volume status using historical data and they should be informing the MIPS eligible clinicians and groups of their low volume status prior to the performance period. And in this transition year of 2017, they're looking at initially basing it on 12 months of data from September of 2015 to August 31st of 2016. And in the future, they'll base it on 2 12-month periods before and during the performance year. The other thing to remember is that CMS has told us clearly that they are looking for feedback in certain areas, and these rules of the quality payment program may be adjusted slightly from year to, or they will be adjusted from year to year based on feedback from clinicians. So if there's ever an open comment period, it's really important to make sure that you're putting your 2 cents worth in and how that affects your organization. And I just put some examples of Method 2 Part B professional services that could be billed under Method 2 healthcare. This is the QPP website and help desk. About 80 to 90% of what you need to know about the QPP is on this website. They have great resources. In fact, the benchmarks for quality performance data just were published on this website last week, Thursday. And it is under Education and Resources on the upper tab of the CMS website. Excuse me. The MACRA homepage, there's a web page on MACRA explains that legislation, and the Quality Payment Program homepage. Other resources are listed here. These are the acronyms, and I have just a few minutes for questions.
Thank you so much, Lisa. That was excellent. There were a few questions that were sent in through the chat box, and you may have covered them, but I'm just going to start at the top and read them off. And if anyone else has any more questions, feel free to type them into the chat box as well. The first question, only physicians that impact my facility are rotating ER doctors. We bill for their services, but doctors change so frequently. What if we don't have the same doctors in 2017 as are here in 2019?
So that's, Julie, you almost answered your own question. So you're right that you do need to report if they meet the threshold of that $30,000 or 100 patients, and they're billing to Medicare Part B. But if you have different providers in 2019, the payment adjustment is associated with the NPI plus 10. Not that we want you to be rotating your ER providers at all, but if you have the same ER and pretty stable ER providers, you definitely should be reporting them under MIPS. And if you do group reporting, and I'll go into scoring next week a little more, but when you do group reporting, the whole group adds their measures together so that you could easily put them in under a group reporting option.
Great, thank you. And if anyone has any follow-up questions, Julie, if Lisa didn't answer your question, just feel free to type more into the chat box. Lisa, the next question is, if a critical access hospital uses a group that is not hospital employees, is the hospital affected by the payments, or is the hospital group?
Whoever's doing the billing. You know, so it really depends on who's doing the billing. And the eligibility is at the clinician level, but as you know, clinicians assign their benefits to hospitals or organizations. So if they're assigning you your benefits and you're billing with your TIN, and their NPI, it's you that gets the payment adjustment.
Great. With regard to improvement activities, what is considered to be medium and high weighted areas?
So I'll give you a couple of examples. If you're part of a medical home model, that is a 20 points. If you associate it all with a quality innovation network or quality improvement organization, that's 10 points. You know, access. They're all listed under the qpp.com, cms.gov website, and you can go and look. In fact, you can even separate them out and to your setting for ER.
Great. Let's see. If a critical access hospital utilizes Method 2 billing, are we ineligible for MIPS?
No. Using Method 2 billing is actually billing to Medicare Part B. So then you're eligible. Your clinicians are eligible. And the eligibility is determined by if that clinician is seeing less than 100 patients, they're ineligible, or billing less than 30,000. But if they're seeing more and billing more, or billing more, I shouldn't say and, it's or, then they are not subject, maybe I'm saying that backwards. Less, you're not subject to MIPS. More, you're subject to MIPS. So if you can disqualify under the low volume threshold. And the Part B payments include Method 2.
Great. How do we submit data? Is there an active CMS portal or attestation website for this program?
Actually, I went in that submission methodologies and how to submit, and it depends on if you're submitting as a group or as an individual. So through your EHR vendor, you want to check with your vendor if they can submit, or if you need to get a qualified clinical data registry, or the CMS web interface if you're over 25 in size. But I would assume that some of you might be over 25. But the EHR vendors are very much aware of quality payment program, and you should try to work with your vendors first. That will probably be your least expensive method. But if they're not, then the qualified clinical data registries are your next step. And there are some lists of, and I'll put that on for one of my future webinars, to put the list of the qualified registries.
Sounds great. With PQRS EPs that billed via UB forms were exempt from reporting. Does this apply with MIPS as well?
It depends more on the what. Is that listed on here? I'm going to read that one, or have you repeat it?
Yes. With PQRS, EPs that billed via UB forms were exempt from reporting. Does this apply with MIPS as well?
It depends on the type of billing you're doing, not the type of form that you're using. No.
Okay. What if a critical access hospital does not use Method 2 and they bill physicians to the Part A carrier?
Then they're not billing Method 2. Nothing affects Method A, Medicare Part A. Part A is not included under Quality Payment Program in MIPS.
All right, great. Those were all of the questions that we have now. And if anyone else has another question or thinks of another question, feel free to contact me and I will get in touch with Lisa. Lisa has 2 more webinars coming up on MACRA next Tuesday and next Thursday, January 10th and January 12th. And you can get registered if you aren't already on our conference, on our website. If you could please complete the short online assessment by clicking the link on the screen. And Lisa, I want to thank you again for today. So much great information, and we look forward to the other webinars in this series.
Thank you for the opportunity. My pleasure.
Yeah, absolutely. Thanks, everyone. Have a great afternoon.